like to thank all of you for spending some time with us this evening. I know you have lots of things you can do after a busy day at work, and coming here and getting a little bit of lecture time is appreciated, and we're happy to have you, and we hope that you find tonight useful. I think it'll be, I'm going to kind of just sort of lay the groundwork for, and Dr. Sturbaum's going to do a case later here when we finish after dinner, and give you an idea of really kind of how this procedure SMILE works. And we're really focusing on SMILE tonight. I'm going to talk a little bit about light adjustable lens briefly, just because it's the newest technology we have in the office, and it's pretty exciting. So I want you to have a little bit of information on that as you go also. But I'm going to be primarily focusing on SMILE. We've been doing these procedures now for a while. We got the laser earlier this year. And Dr. Croskrey, myself, and Dr. Sturbaum have all been doing cases kind of consistently. And we're really enjoying having the technology. It's definitely something that adds to the toolbox for us as refractive surgeons. There's reasons to do this procedure, and they're fairly definite, and we'll kind of go over that, and can answer some questions as well. But I think you'll find it, for those of you who may be kind of still new to learning about this procedure, I think you'll find it informative, and hopefully you'll find it as something that's attractive for your patients. I'm going to kind of just briefly go through slides with this, and we'll talk about a few different things, just some disclosures. I do consult for Zeiss, which is the company that makes the SMILE laser, so just for disclosure there. As far as the way SMILE works, what this procedure really is it's kind of it's a derivative really of laser, of LASIK, but it works in kind of a little bit of a different way. What happens here really, and here you can see that what we do is we make some laser cuts, and we use one laser for SMILE. There's only one laser used. When we do LASIK, we do use two lasers. We have to move the patient from one laser to another, and we don't have to do that with SMILE. But what we do is we're essentially making a lenticle. We're making a laser passes through the cornea in a posterior level, and then it passes a second time anterior to that first pass. And by doing that, it creates a lenticle, a loose area of corneal stroma. The laser then makes an opening into that space, a small little opening that we then can enter, and then we go in and we remove the lenticle. And so the lenticle is taken away, that space closes, and then the patient heals, and that changes the shape of the cornea. And so that's essentially the principle of how SMILE works. It's very quick. It requires a little bit of manual dissection, but once you do that, then you're pretty much done with the procedure. So from the standpoint of the surgeon, it's a simpler procedure for us to do than LASIK. It goes by a little, and it also has the potential to be a lot quicker for the patient as far as the time that they're having something done, because we don't have to move them from one laser to another and go through the steps and all that. So it's a procedure that's has a pretty good track record now. It's not new in the sense that there aren't very many done. There's been probably over 3 million cases now done. And so it's a procedure that has there's a lot of data that's out there on the procedure. A lot of studies have been done, so we know a lot about it. And this just kind of shows the growth of SMILE since it first started. And the very beginning SMILE procedures were done, almost 10 years ago now. And over that time, there's been a very steady growth in the number of SMILE cases that get done each year. So it's definitely a procedure that's growing, and that tells you that it works well. If this was a procedure that was difficult, or we had a lot of complications or issues with, you wouldn't be seeing that elevation. If we look kind of just, again, just kind of going back on that, just there's 1,800 surgeons. There's over, I'm not sure how many Visimax lasers are in service right now. It's over 1,000, I'm sure by now. But probably 2,000 surgeons at least. A bunch of peer-reviewed journals. There's, you can look up SMILE, and there's a lot that you can find there. And there are surgeons now that are gaining lots of experience, and we certainly hope to be in that group as well. If you look at kind of where some of the lasers are distributed, I think the thing that's really interesting here is Asia and Europe It's a very fast-growing procedure in those areas, particularly Asia. It's really supplanted LASIK essentially in Asia now. In South Korea, Japan, China, those countries, if you were to go there, it's almost exclusively now SMILE. LASIK and PRK have really kind of are on the way out as far as the procedure that's being done in those countries. Europe has been very also a robust growth area for SMILE as well. There's a lot of SMILE surgeons that are very prolific in Europe. So it's definitely not it's not on the fringe. In the United States, there's I'm not sure how many lasers are now in the U.S. Probably over 100. We're the only ones here in this area that have the laser. Over in the Seattle area, it's available, but for this region, for your patients, this is the only facility. I think it's interesting. The military has also taken SMILE to heart. The Navy, the Air Force, the Army, they all are really providing this procedure. And it makes sense when you think about it because there's no flap. And that was the biggest, for some of the branches of the service. I was in the Navy. In the Navy embraced LASIK fairly early on for their pilots and for SEAL members and so on and so forth. But the Army was kind of slow to do that because they just had a lot of concerns about the flap. And I think the Air Force was similar, and Jason can probably speak to that better than I can. But SMILE there is no flap with SMILE, and so it kind of takes that whole situation off the table. So for active duty military, depending upon what it is they're doing for their job, certainly infantry and people that are in harm's way, not having to have to worry about any kind of traumatic flap issues is a very nice thing, and SMILE delivers on that. If we look at just kind of what some of the results are with SMILE, they compare very favorably with LASIK. With the right candidates, patients do very, very well. If you look here, just after 6 months, uncorrected visual acuity. This is just straight one surgery, and that's it. And this was from the FDA study, so this is out of the box without making any kind of adjustments. We have the ability to make some fine-tuning adjustments and things on the procedures that we do. And so that allows us to even get a little bit better numbers than what you see here. But if you look, 84% of patients are 20 or better. Half of patients are 20/16 or better, and those are pretty good numbers, and that compares favorably with LASIK. Everybody pretty much gets functional vision with this procedure. Again, just kind of taking a look at comparisons with SMILE versus LASIK procedures. In the gold and the green and the gray, these are LASIK, LASIK units here, and then the two blue are SMILE. And SMILE with and without astigmatism correction, and you can see you're really right in the same ballpark with LASIK. So when you choose SMILE, you're not getting a procedure that is less than what LASIK would give in the proper candidates. Again, just kind of looking at some of the predictability, how the accuracy or what the accuracy is for this procedure. You can see that, this really is kind of what we're looking at here. And with SMILE, being within plus or minus a half a diopter in spherical cases and then cases with cylinder. And here you can see, these are patients that had a fair amount of correction prior to their surgery. We're right in the ballpark of where you want to be for those folks. Those are really, I'd love to get that kind of accuracy with my cataract surgery. But so the procedure works well and it's predictable, and we've been pleased with our results as well. So here again, just seeing that, just kind of the comparison here. It's across the board, the preoperative cases. And then all those patients within, it compares very favorably with LASIK. These are some of the studies. I just put those up here. There have been a fair amount of peer-reviewed articles. This is the study results from the FDA. And again, just kind of reiterating those same numbers that these patients have all done really well. 84% had better than 20/20 or better at 6 months. and that improved over the year time and went up to almost 90%. So this is a procedure. Kind of just talk through it very briefly, and then it gives you a little bit of an overview, so when you're watching Dr. Sturbaum's case, you have something to compare it to if you haven't seen. So the patient, we're looking through the microscope now. We're docking the patient's eye. The cone is coming down onto the patient, and this is a green fixation light for the patient to look at. And we're just telling them, look right into that green light, and you want to just try and center that. Now here's the first pass. That's the inferior pass. Laser's making that. As you can see, they're fairly quick. And we're just telling the patient, look at the green light. Now here's the anterior second pass coming across. And then there's going to be the side cut gets made. And then that's it. And so it's pretty quick. So for the patient, what's nice about this is for the patient, the time under the laser is just very short. Now the next step is to go then and go into the side cut area, which is right here at the edge, and you identify the two different layers of tissue, and before you dissect them free. And so right now the anterior segment of the flap is being, or of the pocket is being dissected, and we get that nice and open, and then we go in underneath that and dissect the inferior portion of the pocket and just get that open. So now we have the two planes identified that make up the lenticle. And once that's done, then we go in with a little bit of a larger dissecting tool. This is a fairly blunt instrument, so that we can't really, you can't just damage the cornea or the lenticle with that. And again, just checking the two different, making sure we identify the two different planes. Then we go into the anterior plane and just dissect that free and just go across in sweeping motions like this. And during this time, the patient's just, looking straight ahead. And you can see there's really not, it's fairly straightforward. Once that's been done, then we go into the inferior portion and do the same thing. And it's important to get the lenticle completely free, so once we're done with this process, and we just take whatever time it needs to do that. Some dissections are easier than others depending upon how the cornea is. Sometimes it's easier to move through the cornea. But once this is all completely freed up, and that just making sure that you have everything free there. And it's kind of hard to see, but you can kind of tell there's a loose tissue right in here, and that's the lenticle. Then once we're done with that, oftentimes it'll just come out with that maneuver when you bring that device out, but you can go right in and just grasp it with some forceps and bring it out, and there's the lenticle. It's done. Then we just sort of smooth the surface a little bit, and then that's pretty much it. And so the procedure, once the important thing is just getting identifying the planes and dissecting them free. But beyond that, there's not too much else really there. It's just a matter of kind of getting comfortable with that process. And so then that's the end of the case, essentially. Post-operatively, these patients, as you get better as a surgeon in dissecting, as you get better doing that process, there's less manipulation of the tissue of the cornea, and then there's less edema the next day. But most of these patients, I think, that we've been seeing, they're seeing in the 20/40 range the next day, 20/30, 20/25, right in that range. So it's equivalent to where we're seeing most of our LASIK patients. In the early days of SMILE, with some of the different energy levels that the laser was using, it was harder to get those kind of numbers. But now with kind of refinements in the way we do the procedure and refinements with the laser itself, it's pretty common for patients to be in that 20/25, 20/30 range the next day. And that's confidence builder for them, and it's they have functional good vision. And then it comes in from there. If we look at, this is just, I'll skip through this, but this is just, you can create a nomogram, putting in information here. This allows you to create a nomogram that will tell you, okay, if this person's a -6, then this is the nomogram says treat minus 6.6 or 6.06. And so we can do that. We have a nomogram that we currently use for our laser to try and refine our results a little bit more. So what are the benefits? Why are we doing this? Why did we make this investment? I mean, it's a $500,000 laser sitting in there. So why do that? And for us, our philosophy has always been if we can find technology that benefits our patients, we want to be part of that. I mean, that's just basically the way this practice functions. It has from the beginning that I got here, and we'll continue to always do that. And we thought that SMILE was one of those things that we really wanted to have in our armamentarium for a few different reasons. It's less invasive, and I think that's something that the patients can understand. If we tell the patient there's no flap, that's a significant difference. And a lot of people really worry about the flap and are afraid of having this flap on their eye and so on and so forth. So we can say, well, we have a procedure that will give you fast recovery and doesn't create a flap, so we don't have to worry about those issues. We think that maybe the biomechanics of the cornea are better preserved in this procedure as well, because we're not really cutting through Bowman's layer. The Bowman's layer and the stroma beneath it are unaltered in SMILE, except for that very small little area where we make the pocket, and that's the only area where there's a cut through that. Everything else is deeper than that. So those anterior portions of the stroma, which we think is the strongest part of the cornea, is untouched. We don't do anything to it. And you can't say that with any of the other procedures. You can't say that with PRK, and you can't say that with LASIK, because we cut 360 degrees through that structure. And so with SMILE, we're not doing that. It's just the one laser, which is nice. Post-operative management is essentially, it's simpler than LASIK really, because we'll never get a phone call at 6 o'clock in the morning saying, I think I dislodged my flap and my eye is really hurting or something like that. That's not possible with SMILE. You can't have that phone call. And nor can you have the phone call where I think I lost my contact and my eye is really hurting for a PRK patient. That call's not going to ever happen either. So with SMILE, we've eliminated some of the things, really the two most common things that we as LASIK surgeons or refractive surgeons have to deal with post-operatively, as an urgent issue. Those are off the table. So for SMILE patients, the post-operative management, they use drops just like we use for LASIK and PRK, but that's pretty much it. And then just giving it time to heal. We also think that there's some benefits for patients with dry eye. Again, because we're not really interfering with the corneal nerves except in that very small little area where we make a side cut for the pocket. Other than that, we're not really destroying any of the anterior corneal nerve plexus. That's staying intact. And again, with PRK and LASIK, we can't say that. And certainly, as you all know, a lot of the patients that come in for refractive surgery are self-selecting because they have dry eye issues. They can't wear their contacts anymore, they're uncomfortable, or you name it, and they want to do something. So I don't want to have to wear contacts anymore. Maybe I'll look into having that procedure done, and then they'll come into your office and you look at them and they've got dry eye issues that you got to deal with. We worry about that with LASIK, and Dr. Claypool is resident expert on managing dry eye pre and post refractive surgery, and he can tell you all about the ins and outs of that. And if there's a procedure that we can do that can reduce the incidence of dryness after refractive surgery, that's an important thing for us to offer patients, and we think that's a big deal. And I think that's true. And there's some studies that are going to, over time, will show that, and it's starting to show that.
You mind, Mark, if I throw something too? Thanks for that too. So I was kind of a little bit hesitant when we were adding SMILE, to be honest. I was like, do we need it? I mean, it's like we already have such an amazing surgery, and they all do such an amazing job with what we have. So honestly, I was kind of hesitant. Like, do we really need this? And like Mark was saying, most of this dry eye that we see is just because the patient, we weren't treating it enough ahead of time. Right? Like, we screened really heavily for it with MGD and the dry eye beforehand. And again, we've had great success with it. Yeah, this is just like greater icing on the cake. Like, now that we've had it for a few months, I can honestly say we see these patients with less dry eye, because like Mark said, something with that corneal nerve plexus, the way it heals, it's cool. That's the easiest way to say it, but it is. It's actually really neat. Yes, we still have to manage their MGD, and there are other dry issues if they have them. But just to have that potential to have that better healing, I don't know if Chris has shared it yet, but we've had patients, maybe Mark shared it, I missed it, that we did one eye. And
Yeah, that's what I was gonna say.
Yeah. You want to share it?
Yeah, the eye with Smile had less dry eye. I mean, less SPK staining, felt better, less symptoms, so they were more happy.
So it's like when I had LASIK, you know,
When I had
Smile.
LASIK, because if there's a scar, sometimes we won't do Smile, because you really can't dissect through that, so.
Yeah. Now, that's not to say that, someone with serious dry eye should have this procedure. That's not the issue. But, those people are easily identified in your office. It's those other people, it's those people that maybe they got a little bit of dryness and you're not sure, or maybe that's not really coming through in what they're describing to you, but then you do a procedure and then it shows up and then you're like, oh, okay, wow, that really was there. So this could be helpful in that scenario. And I think that's a fairly large number of people that we see in the refractive surgery community, is that kind of sort of in between folks. So I think that's a big benefit. So who can have this procedure? Well, the FDA approved Smile for treatment of myopia from 1 diopter to 8. So that's the range that you can correct. And it's approved for up to 3 diopters of astigmatism. So that's kind of where we can go. So that covers really most of the people that we would do LASIK on. Now, we can do LASIK on patients who have higher degrees of astigmatism than 3 diopters. And so there are going to be some individuals where we may feel that it's better for them to have LASIK because we think we can correct their astigmatism better or that. But Smile is able to correct astigmatism up to 3 diopters per the FDA. My range is around 2 1/4, 2 1/2, somewhere in there. If it's above that, I think in my hands I can do better with the eye design system that we have. So that's kind of where I am with that. The other thing is that if you have low degrees of nearsightedness, minus 150 or 175, something like that, the lenticle that you make with the laser is pretty thin, and it's pretty delicate, and so that requires the possibility of tearing the lenticle inside the pocket and maybe leaving remnants behind or something like that. That does exist. And so for me, again, at this stage really anyway, I like to be a little bit above 250, somewhere in there as a myopia, because that's going to be a little bit more of a substantial lenticle that will dissect easier. So I'm kind of in that range for that. So that's me personally. I think the other doctors, I think Dr. Croskrey and Dr. Sturbaum are probably pretty much similar to that. Not a big difference there. I think we're all around in the same boat as far as what we'll do. So that's the parameters by which we can treat. And then of course, although I think there's more biomechanical stability to the cornea with Smile than there would be with LASIK, we still have to be careful with patients who have irregular topography. There are ectasia cases with Smile. There are cases that have occurred, and so it's still something that we have to follow all of those safety precautions that we normally do with patients who are having Smile, just as we would with LASIK. And so at this stage, that's really kind of what we're doing. If we see data down the road that says that you can be a little bit more aggressive, then we'll look at that. Right now, if somebody's got irregular inferior steepening or an irregular cornea of some kind or whatever that makes you go, we'll probably it's the same things apply for these patients. So that's kind of gives you an idea of what to expect as far as that goes, and who can have the procedure. I'm going to stop right there for a moment and just see if anybody has any questions, or if there was anything a comment that anyone wanted to make. Yeah.
Is there any difference, like halos, like
yeah, I think we've gotten really good at that just in general. I think that the eye design laser program, the likelihood of having significant halos at night is really low now, with patients, I think, and Smile continues that, and if anything, it may be a little bit less. But I think that's an issue that I think we've really kind of tackled for the most part. Does anybody really get very much complaints in your patients of nighttime glare and issues at all like that? We don't see too much of that anymore.
Yeah,
so we're not sure.
I hardly see that now.
Yeah, it's just rare. It's really more the dryness, I think, is just, that's our biggest concern probably really right now with that. I think we've nailed a lot of things otherwise. So was there another question? Pardon me?
Do you do post LASIK?
Oh,
Under LASIK?
no, if a person's had a flap, then they would preclude this. This is all virgin eyes I was talking about before. And that's a good point. I didn't say anything about enhancement rates for SMILE are low, about 2%. That's kind of about what it typically is. So there are patients that may need a secondary procedure. Really, at this point in time, what we're doing for those patients is a surface laser treatment on top of the SMILE, and you can do that fine. And so, but that's if we need to do a retreatment. We haven't done any retreatments on any of our patients at this point. But if we did need to do that, that's how we would do that. So, yeah, and that's easily done. So, and works fine. I'm going to talk just for a moment about the light adjustable lens because we're really excited about it, and I don't know how much all of you have a sense of this, but it's all right in your wheelhouse. So if you don't know a lot about light adjustable lens, let us teach you a bunch about it, because I think as an optometrist, I think this is a really exciting development in cataract surgery, and something that we're going to really, we're going to rely heavily on the optometry side of things for the success of this procedure. And so for those of you who don't know, the light adjustable lens is a cataract system. It's a lens that we place in the eye at the time of surgery that has a photosensitive film to it that allows us to post-operatively adjust the refractive status of the lens. And so a patient, we can put the lens inside a patient, we can then let them heal from their post-operative surgery, or go through the post-operative period, and they're 3 or 4 weeks out. We can measure whatever refraction is there, and then we can take them to a device that's just done in the office here. It's just a UV light box that then will create that, it will send impulses into the lens, activate that polymer, and change the shape of the lens slightly to create that, essentially create that refraction in the lens. And so by doing that, we can pretty much personalize everybody's cataract surgery. And it's kind of like making a custom suit for everybody. I mean, we're going to measure and remeasure and measure again, and then we're going to put that in there. So it really allows us to really dial down the endpoint result for where we want a patient to be for refraction. And where this procedure, I think, will really shine the most for us is in our post-LASIK patients. Because those patients have already gotten used to this very high, I mean, you saw those numbers, 94%, that's pretty good, half a diopter, that's pretty good vision for the vast majority of people. And as all of you know, you see your LASIK patients, they see great. And they have this very sharp and clear vision that's pretty typical. And we strive for that with cataract surgery, but we're not really exactly there right now. We don't have that level, especially in post-LASIK patients where there's some variability in terms of how they might turn out. I have a patient, I saw him post-operatively today, he's post-LASIK, and he had kind of mini monovision, about a -175 in one eye from his LASIK. And it was just wonderful for him. He loved that life, and that was perfect for him. He had great vision and distance in one eye and could work at the computer perfectly in the other. And then he got cataracts, and all of a sudden he can't really do all that stuff anymore, so he wanted surgery. We did his surgery. His post-operative result in his dominant distance eye ended up perfect. Everything looked great. And I used exactly all the same criteria, the same A constants, the same IOL formulas that I used for LASIK or for post-LASIK in his distance eye, and set it for his reading eye, or for his intermediate eye. And I set it for -1.75. That's what I was shooting for. And surgery went great. Everything went fine. Nothing unusual. Laser cataract surgery case. Very simple procedure. And he was -3 at the end of that. And the lens said he was going to be -0.7 or 1.75, and his distance lens says he was going to be plano, and it was. So you would just expect everything to work out fine. Well, it didn't, and he's not happy. And so, I got to deal with that now, and so I got to fix that. This takes all that away, makes that all go away. If he had light adjustable lens in that eye, I could say, hey, don't worry about it. Just for this next 3 weeks, we'll just live with that. And then we'll get you settled, and then I'm going to bring you to the light, we'll treat that, and we'll put it right exactly where you want it to be. And so that's really, I think, a great thing to have, available to us. So and we do LASIK cases now, cataract surgery. We do cataract surgery on LASIK cases every time we're in the OR. I had 4 today, so we just see a ton of them, because all those people are coming to cataracts now, or coming to cataract surgery now. So this is going to be a huge thing for us, and so I think. And it's good in all other kinds of ways. Just imagine any other way that this might be beneficial for a patient. It's not hard to think of a bunch. Patients with irregular corneas, patients with cylinder that's just not completely, you can't quite nail it down, those kinds of things. And so people, RK patients, and try to find one that works best for an RK patient. There's a lot of great opportunities for people with this type of technology. And so we have it available now. We're doing cases now. We just started. The 3 of us just started 2 weeks ago, getting them in. So we've got some people moving through the pipeline. So if you have patients out there who are a little skittish about surgery because they're wondering about how they would end up or that sort of thing, we really do have something. And this gets them under half a diopter. The data on some of these are the number of patients. Well over half the patients are seeing better than 20/20 uncorrected. 2010, 2015 vision after cataract surgery with no glasses. And that's pretty impressive. And again, we're the only people that have this available in the area. And so, if you have patients that you think would benefit from this, and I'm sure you do, we all do, I think it's really an exciting thing. And so it's a great technology that we have coming up on board now. And again, your role post-operatively is more important now maybe than it ever was, because you're going to be doing those refractions. You're going to be doing those measurements, and finding where's the perfect place for this patient, and who better to do that? And certainly not me, I can tell you that. I consider myself a very good surgeon, but when I have to bring the foreopter down, things are a little different. But all of you, that's how you make your living. So we're excited about it, and we're excited about the way we can join forces for that. Yeah.
What's the range that you could adjust it?
You can adjust. You can do 3 treatments typically. You can do about 3 different treatments over that period of time, and in that period in the treatment, you can correct 2 diopters of refraction. So, for example, so there's planning that takes place here. Because if you have somebody who has a lot of cylinder, if you're going to correct 2 diopters of cylinder, you can't really correct sphere. So if you're going to correct 2 diopters of sphere, you can't correct cylinder. So you have to find the range, and you say, okay, we can get this in 2 treatments. We'll correct some of your cylinder and most of your sphere this time. Then we're going to give it a few days and see how that is. I'm going to re-refract you, see where we are, and then we're going to correct the rest on the next one. And so you can do 3 to 4 treatments, and then you do a final lock-in treatment where you lock it in and freeze it in that spot. So there's work there. It's not a simple, have surgery and off you go. And the patients need to know that. There's things that are involved here in terms of their care. But if you want to really get to that, fine level of vision, this is the path we take. So, any other questions?
Could you remind me, what's the time frame to have that done? Does it have to be done within the first 3 months?
Well, typically, you want to get, the other thing is that you do have to be careful about ultraviolet light exposure while the lens is in place, and patients are educated on that. And so you don't want to have to deal with that for months, so you want to get the process going. If you wait a month, that's plenty of time really to get that started. All right, I think that is the cue for moving on. All right, well, thank you, appreciate it. And like I said, we're really excited about all these things. And I think they're a great option for your patients, and so we hope that you feel that way too.
So oddly with the lights, that's an automatic time, and we were not trying to tell Mark to stop talking. That was fantastic.
So now they're going to move the patient under the other microscope light, and that'll take a minute. So yeah, if any of your friends or family, you had LASIK,
Yep.
right? And so the pressure is about 100, and it's a lot of pressure.
and you cannot see anything because the optic nerve gets zero, blood during that time. But with Smile, the pressure's much less, and you can see that green light the entire time. After the first pass of the laser cut, the green light does kind of go away, so I tell them, don't move, keep looking straight ahead. But it's very cool, and I've docked people with it, and it's very comfortable. A lot of people say almost like a soft contact lens. So now you can see he moved them under this other microscope light. There's two different systems to visualize, one for the laser cut and then one for the dissection. And it looks like we're having a little bit of a glitch, not too bad. But so he's just going to anesthetize the conjunctiva here with some proparacaine or tetracaine. So we'll hold that there for a minute. And then I think all of us have been using a forceps to fixate the eye. The eye moves around if you don't do that. So we'll grab that. That sometimes does cause a subconcheme, but there's almost no subconcheme from the laser. With LASIK, you got a lot of subconcheme because the pressure is so high.
That's the nice thing too. They're having surgery the next day. It's white. It's quiet.
Yeah.
Sometimes I tell patients, well, just make up a story that you saved a baby getting run over by a car or something. It's just,
Yeah.
So yeah.
So he's entering the incision down here, and out in this about 0.5 to 1 millimeter area, it's just one plane. So you kind of start out there. You can kind of see the other plane right here. So he's dissecting that anterior plane is the first step. After the anterior plane, he's looking for the second posterior plane, and that's where he's going here. And then he's bringing those two to see how they meet up. That's great. Yeah, this is probably, for us, when we've had a few patients in a day, it's been faster than LASIK already, even though it's, I don't know how many thousands of LASIK were done here before I was here, but a lot. And so LASIK's, we're very comfortable with it, but because we don't have to move the patient to another laser, either you have to swing it in a chair or move to another bed, you just move the patient up to the other fixation light. It's been great to streamline that.
What was the depth again?
So the cap, instead of a flap, we call it a cap, is 120 microns. And in the US currently, we cannot change that. Is that right?
Correct.
With the 800 maybe in the future, yeah. So, so it's 120. With LASIK, we can adjust that more to like 90 if we want to stay more anterior. So the cap's 120. The depth of the lenticule depends on the refraction, a lot like LASIK. And we have a calculator and a graph to look at that. Depending on how much cylinder they have, it changes that a little bit too. So after he defined those planes, now he's going to enter with this other side of the instrument, the blunter end, to dissect that. So he's, going for the anterior right now. Yeah, and that looks like a great dissection. Awesome. And so, so usually we're holding with this hand, with the non-dominant hand, and then dissecting with that hand.
How much resistance do you feel during this?
It's a little bit variable, actually, depending on the room temperature. And I've even noticed a few degrees difference can change it. But a little more than you would expect. And yeah.
Not enough to sweat at least. Like this is...
Yeah, not sweating because of physical energy, but when you're starting, maybe a little bit of mental energy. Yeah. And so now he's going to go for the posterior edge here. And so what you're feeling for the posterior edge is you want to feel that resistance again. If you have no resistance, you kind of know that you're still in the anterior plane. And yeah, so we were talking about how some people have had LASIK in one eye and Smile in one eye. One of them was actually, I guess he gave me permission. It's my cousin, so it's not too, but anyway, he had Smile, and a couple of people have had Smile in one eye and LASIK in one eye because of a scar. And people have preferred the Smile eye, even the next day. The incision for LASIK, the epi has to heal, that whole flap. And with Smile, the only epi that has to heal is right here. And so they've been telling us when they have 1-in-1 that there was less pain with the Smile eye. And LASIK's usually by the afternoon or evening is when it's healing, and it's about half that time from those patients with Smile. So now he's dissecting in the posterior here. I can see the resistance. And this is kind of this double bubble sign where we see a group of bubbles that are underneath into the posterior plane. And so you kind of want to leave these edges by the incision for the very end, because that'll kind of keep it in place. And then I often, I'm left-handed, so I kind of leave this side for the end. He'll probably leave this side for the end, so he'll probably finish over here. And yeah, he's almost done. That's looking great. So, and I can see that lenticule moving around. That's that tissue right there. So he's getting pretty close to bringing that out. Yeah, there's the end on that side. And it is folded up here starting, so it's definitely mobile, which is awesome. And so he's just sweeping anterior to pull it out, and there it comes. Every time I've been doing it, I still unfold the lenticule on the cornea just to look at it, make sure that it's complete 100%. If you do have any tags that are left behind, that'll give you some abnormal corneal shape and some higher order aberrations, so you want to just make sure of that. And yeah, it's been a really enjoyable procedure to do. And I heard, some that it can be a learning curve, but it's been easier than I think I anticipated for all of us to do, so it's been great. Awesome, there it is. He's all done. So now he'll just unfold it and check it and make sure, and it looks perfect. Yeah.
This is actually fast forward. We're not watching it live. Just
No, that's it. Yeah.
I'm just kidding.
Awesome. That's it. All done. Very cool. So yeah, the visual acuities have been great. Like Dr. Kontos was saying, I've been seeing them right in the range he was saying, 20, 40 or even better. And if it is, a little worse than that, they usually come around, but for the most part, that's where our patients have been. So that one's all done. So he'll move over to the other eye. It'll probably take him a minute to set up. So we can probably talk again, and I'll come around when he's going for the other eye.
Jason,
Any questions?
I've seen a couple of times where glitter makeup has gotten trapped under flaps.
Yeah.
LASIK, do you see anything, the risk of being something introduced in there too?
I have not with a Smile case. I had to take a deep breath because I have 4 kids, and anytime you say glitter, but no.
A couple of girls.
Yeah. Not many things do that, but yeah, glitter gets me. So, no, I have not seen anything. I have seen a little bit of meibomian gland oil, and under a LASIK flap and Smile, that dissolves after a short time. I'd see by a month, usually it's gone. And
Call it a souvenir. I don't tell the patient that, but it's a souvenir.
Yeah.
It goes away.
yeah, so I haven't seen anything like that. Yeah, any other questions?
What are any post-operative complication considerations versus LASIK?
It's very similar. The main thing is, if somebody's calling in the middle of the night, we have an answering service with our technicians that take care of that. I'm not going to freak out about a flap dislocation. So if they're like, oh, I'm having pain, I'm going to say it's okay, take a deep breath, close your eyes, and just rest, and we'll see you in the morning. But with LASIK, I'm really worried about a dislocation. And that's pretty rare, but I have seen those. And yeah, it's usually a child with LASIK that they're, holding a kid, and the kid goes at them, or an animal. And so, yeah, so I don't worry about that. But, inflammation or infection is extremely rare, but about the same incidence as LASIK. And yeah, just other rare things, kind of the same thing. Ectasia is a very similar risk profile. Initially, we kind of thought that ectasia would be less because the anterior stroma isn't cut. Like LASIK, you cut that all the way around. So there's some anterior stromal fibers that are still intact. But it's about the same for that as well. Yeah, great. Any other questions?
Can you remind us what size that you have to win to afford it?
It's the same as LASIK for us, and I mess this up every time. So I have been banned from telling anyone any price, because I'll see a patient and I'll say something, and then I'll walk out of the room and the coordinator will go in and they'll say, you like screwed that up. So 2,500 per eye. Okay, that's what I was gonna say.
LASIK,
All the same.
all the same.
Yeah, some practices are charging more for one or the other, and usually Smile, but we really want to do Smile. It's awesome, and so we're happy that we can bring it at the same level. So again, the patient's fixating right on the green light, and one thing I will say is sometimes if a patient doesn't fixate well, this may be a little more difficult, because that's really important. So you see this coming across here, that's the posterior cut, and they're gonna see that green light go away now. So I'm just telling them, maintain right where you're at, you're doing great, keep holding steady, and now that other cut will come through.
Does the laser stop if they move their eye?
So the laser does stop if the suction's broken. You can also stop the laser by lifting your foot up. Because of the way this laser works, it doesn't have, the eye can't move during this procedure, or if it does move, suction breaks. With LASIK, same thing when the flap's cut, but when the excimer is treating the eye, it tracks the eye. So it's a little different. So it's, yeah.
The time difference is really,
Huge.
yeah,
No,
it's
no,
what,
still very
22 seconds?
Yeah, it's around 20 seconds to do that whole cut. And so that's pretty much it. So
Pretty high minus too, isn't
For
it?
every-
yeah, so for LASIK, if you're a -8 or something, it's gonna be like a 1-minute treatment on the Vizix. With this, it's the same, because,
The smell with this.
and you do have zero smell, zero smell. I think there was some ways of crafting that, but yeah, usually you smell, with LASIK, the patient's smelling that the whole time. And I'm hoping their volume's like blunting their, yeah.
Can I share one?
Yeah, yeah.
So not only is the pressure really low, which aids with the patient comfort, but there's an adaptation within the optics of the laser for the focusing light, so that when you plug the patient's prescription in, it matches it to their prescription. So not only are they sensing less pressure and feeling more comfort, they are also staring at that green flashing light based on what they're
In focus, yeah. If you're -2,
fixation.
yeah.
If you have any Zeiss technology in your practices already, then you probably know Germans like to build really nice things. They even built into this treatment a smart bed. So if the patient moves at all during the procedure, the bed senses it and adjusts and put them in the right position to aid with the procedure itself. So.
I've had way less problems with patients moving with Smile than with old laser, because the pressure was so high. I mean, if you push on someone's eye to give them an IOP of 100, they don't, that's, yeah, but this is so comfortable. So it's been great. So yeah, like if you imagine if you're a -9, your distance of clarity is going to be different than if you're a -1. And so that's what Matt's saying here. Matt, right?
Yeah.
Okay, it just adjusts that automatically, so that the light's still clear regardless of your refraction.
So I was like per prescription when I had LASIK 24 years ago. And the doctor was like, stare at the red flashing light, stare at the red flashing light. I'm like, come on, I can't see that. Like, -5 is -1 still. It's just a blob. So to have that adjustment really helps with, right? Because with LASIK, you can really anchor on, right? And you're there. But with a softer touch, that cooperation is really good.
Do they still get it like a sedative before?
We do currently, for the most part. I've done a lot of surgery with all kinds of sedatives, including none, and I find that people tolerate it pretty well. With Smile, where I worked in the Air Force, we're doing it in Colorado, and I actually got to use the laser there before I moved here. It was awesome, and we're not there. But just different locations kind of have a different protocol, and it's usually based on a patient experience, where somebody got volume and then like I gave my kid Benadryl to put him to sleep, and they like freaked out after that kind of thing. And then other people do really well. So it's, yeah. I find it really variable on people's preference.
Yeah, I see it all across the West. It varies on what they do. They could offer it. A lot of patients, I think, nowadays, based on a generational mindset, just don't want things that alter them. So a lot of them will decline it. And then when they come out, they immediately say things like it felt like air, or it felt like nothing, or it felt really soft. So they don't necessarily need that. The key is the verbal anesthesia, which you guys are rock stars at, to kind of talk the patient through every step so there's no surprises. And then they're just really focused on the voice, so that the medications can be a little more obsolete.
So I'm pretty sure he's already on the posterior here, so this is great. Yeah, both these dissections have gone really well.
Almost like there's glitter in the eye with the color.
Yeah, that's just you don't see that in the microscope. That's just the TV thing. And so yeah, we kind of leave the outside edge for the very end. And so he's dissecting that outer lip of the lenticule right now. And there it comes out. So awesome. That looked perfect. And I'm pretty sure he'll unfold that just like the other one to take a look and make sure that there's no issues with it. And yeah, that looked really great. Yeah, I don't know what her refraction was.
It's like -5 or 6. I should.
Okay. Yeah, I love it when it's, -4 or more, because then I'll just tell them, can you see the clock? It's really great, because it's not going to be clear vision right away, but it's definitely going to be better than glasses off. So perfect. That looks great.
That scraping. Are you not causing abrasion?
So you're under the epi, and out here.
Right here with the.
Oh no! If you lubricate the cornea, you can have. Yeah, you can. Yeah. Yeah. If you don't lubricate the cornea, then you will abrade the cornea. And we do that intentionally for like a keratectomy if they have EBMD. I just saw a lady today that we scheduled that for, where they have so much scarring around and their astigmatism's insane. So we will scrape it off intentionally with a similar instrument, but just no lubrication. But yeah, if you have irrigation, some type of fluid, then yeah, you can really. Awesome. I think that's it. Any other questions?
Do you want to feel free to ask more questions? We have a little more time. We have to be compliant with CE, so we can't just cut off a little bit too early. Do you mind talking about ICL while we're on topic of surgeries? And
yeah.
Because we know there's a wide range of platforms for surgery patients. So yeah.
Thank you. Yeah, that's great. So we're wanting to just make sure that everybody knows that any refractive patient is welcome, regardless of age, prescription, or anything. What we do to treat that is going to vary based on that, but anyone is welcome. So if someone's outside the limits of LASIK or SMILE or PRK, we have other procedures that we can offer them. And the ICL is a great procedure. It's very popular in the military, so that's where I got introduced to it. And then there's a new ICL that got FDA approved this year, and it's called the EVO. And the benefit of that one is that we don't need to have any PIs created. It has holes in the lens. The PIs were the worst part. And so I love that. The cataract and glaucoma risk looks less on all the data that I've seen so far too. Those are the two things that I worried about. So instead of when a patient comes in, it's not really a LASIK consult anymore. It's a refractive consult. And we're usually choosing SMILE for every patient that qualifies. We're finding the best patient experience and everything. So that's our preference. But if they don't fall within that range, then we're allowing. We don't want to say, oh, you don't qualify for this. We don't really word it that way. We just say, your eye doesn't tolerate this procedure because of these things, but this procedure would be a great option for you. So yeah, it's been great. And any questions on that anytime? We'll probably try to do some more CEs because that RX sight lens and this new ICL are this year approved. And we'd love to teach more about it and talk about how it's fitting into our patients. So thank you. Any other questions on anything?
It's funny, one of my friends, so Nate Hawkins from our class, so the Janglas and Allie and I were in the same class at Pacific. So his wife just had, so I've been telling them for years, okay, they lived out in Utah. I was like, oh, once she's -9, almost 10, I think. So yeah, once this new Vivo ICL comes out, I had a surgeon down there, even I knew. I was like, yeah, once this comes in, have it done with this surgeon. And I just saw her last month, and so it was fun to hear how excited she was with this. So it's something, I'll just take a second to talk. So I had, like I shared it last time too, I had my LASIK done, Allie, when was it? It was 2 years ago, 2.5 years ago?
2020, yeah.
So we did it where, I shared this last time, where Mark did Allie's and then Chris did mine. You can share how we did that or why we did that, but.
It was just a pact between him and I. You do it, I'll do it.
So once COVID hit,
Yeah.
I was like, Allie, we're doing it. so I was like, actually more like, Allie, I'm doing it, so it's your turn now. So I think it was like a day apart, we did our surgeries or something.
Yeah.
And Jason hadn't joined us yet, so we didn't have a third eye, so it was kind of nice. We didn't have to, it was a bit hard, yeah. So, so anyway, so we, I held off for a long time, and I think it's a great topic as we talk about surgery because, especially for optometry, you guys see these patients day in, day out, and we want to make sure when you're trusting us with your patients, with your family, these patients are like family, that we treat them with that same respect, the same kindness. That, hey, if you were a family, this is what we would do. And that's what we do. Like, that's what we've been doing, the most advanced technology for so long, because the safety, I'd become more vociferous about that.
Awesome, she's here. How you doing?
Good.
Great. You were a champ in there. Awesome job.
Thank you.
How you feeling? Okay, I'm going to put you on the spot, sorry.
I am so excited. I hope I don't cry and mess it all up.
Oh, crying does not mess it up. You can cry. Crying's safe. Yeah. Awesome. Yeah, you did really well.
Oh, good. I was like, am I holding still enough?
You were perfect.
Oh, good.
Yeah.
Your eye looked beautiful up there, too.
It did.
Thank you.
Yep.
Thank you. I don't know if I can take credit for that, but sure. I'll tell my mom.
Yeah. Any pain, discomfort? How was the surgery itself?
No, it wasn't.
Chris isn't here, so you can tell us about it.
Oh, okay. No, it wasn't painful at all. The laser, I was just trying really hard to look at the green light.
Mm-hmm.
And then once that goes on, I don't know if something goes over, but then it's kind of cloudy. And then at some point it starts looking like you're underwater looking at a bright light, and there's like a little bit of motion, but that was about it. It was numb. I couldn't feel anything. I mean, from the time he put the numbing drops in and like dabbed, and then he started wiping something across, I was like, I can see that, but I can't feel it. So it was good. Yeah.
Awesome.
And it was so fast.
Now he's here.
Like,
so might
whoa,
be
we're
careful.
No, he was awesome. He was really great. So.
Congratulations.
Yeah,
We're so
thank
happy
you.
for you.
And thank you for being here for this, too.
Yeah, agreeing to participate.
Oh, of course. Of
We're
course.
gonna let her go get some rest.
All right. Yeah. Eyes closed, 4 hours. See you tomorrow. Awesome.
Did you talk about the recovery with Smile as well?
A little bit, yeah. Anything you want to say, come on over. I have a mic here.
Yeah, the recovery is much quicker. I told her 2 weeks of no swimming, but Dana says people are swimming the next day. I don't know. As a cornea specialist, probably I'll maybe go to 5 days. We'll see.
Well, you can't have flap complications because you don't have a flap. So you're not worried about dislodged, or displaced flap. We had a surgeon that did Smile on an MMA fighter. And of course, LASIK, well, you're not doing MMA, you're not in the ring for 6 months, right? Minimum. Smile, he was in the ring 2 days later. Because you're not worried about a flap, there's no concern. So you can get back to life faster, you can wear makeup, you can do all those things. So, women that are getting married, they want to get their eyes, treated before a wedding. Do Smile. You can wear makeup right away. You can go on your honeymoon. You can, do all those things, get back to life a little faster. So.
Yeah, they really don't need to wear the shield, maybe the first night, and then after that, don't need to worry about the shield because there's no flap. So no contact lens, no corneal abrasions. You might get a little tiny corneal abrasion at the interface the entry zone, the 4mm incision. But
New subconscious.
patients feel way better. They don't have that post-op 6 hours of pain. They don't really have that much pain. I did a patient with Smile, and it was really thin flap, so it was a little difficult to get out. And so I made him do LASIK on his other eye, and he was like, man, I wish I had Smile on both eyes. And the Smile eye is 2015, and the LASIK eye is 2020. So it was kind of funny that even though it was harder for me to get his lenticule out, he wanted me to go through that pain and suffering again. I was like, no, we're doing LASIK. But yeah, he said the discomfort, his dry eye is worse than his LASIK eye. His Smile eye is fine, and he's a pilot. It's his cousin.
Yeah, my cousin.
Yeah. So.
So we had a question
Yes.
about subconscious.
Yeah, so sometimes,
Iatrogenic when we cause
yeah,
it.
if you hold the eye to fixate, sometimes that will happen, but they're less and they're less severe, so I have seen them much less than with LASIK.
Yeah.
And the reality is, so this procedure is all done on the cornea itself. So we are not affecting the conj. The only time we're even touching conj is when they're fixating the eye to hold it for the dissection.
Yeah, so you could get, I got a subconch hemorrhage on a patient where it just broke a blood vessel, so she had a little 3mm subconch hemorrhage, but it wasn't significant. You got a question?
Yeah, what patient profile are you still choosing to do PRK, or is there any? Do you do PRK anymore?
Well, PRK mostly inferior to superior steepening changes, severe dry eye, which now we convert to Smile, or thin corneas.
Yeah.
So that's about it, you know.
Anterior basement membrane dystrophy, I would occasionally consider PRK. I definitely shy away from.
Yeah, on those patients I usually do PTK first.
Yeah.
And then I've done LASIK after
later,
that, because their refraction can change when you remove the anterior basement membrane dystrophy. So.
Yeah.
So really, mostly now it's just be thin corneas and people with outside the range of safety for LASIK or Smile for superior to inferior steepening changes.
Awesome. Any other questions?
With that, is the Smile incision site, does that almost seal up like almost instantly, where it poses like a little risk for that pocket to get any bacteria within it? And so once you're out of there, that kind of flattens down and it seals up pretty quick?
Yeah, that incision's the epithelium will be over that in 4 to 6 hours, like a LASIK flap. So your risk mostly would be just the first night.
Okay.
So the epithelium grows pretty quickly that's why it takes about 4 to 6 hours for LASIK flaps to feel better. It's because they have to heal that incision site. And since your incision site's only 4mm now, it's not nearly as painful. So.
Yeah, my cousin's Smile eye, he said the pain was gone in half the time of the LASIK eye.
Half the
So I
time.
think the epithelium's healing quicker because it's just smaller.
And I know you said this, but how high of myopia is it FDA approved for?
-10.
Oh,
So we're doing minus 175, minus 1.5 to -10 with about 2.5 diopters of astigmatism. It's approved for more, but right now we've cut it at about 2 to 2.5. Any other questions? Well, thank you for coming tonight. Hope you enjoyed it.
Yeah.